So, good morning, everyone, and greetings from my end. And I wish I'm happy to be a part of this India's longest dental conference. Uh, I also would like to acknowledge the organizers for giving me an opportunity to be a part of this conference. So to begin with, I would like to put up a question to you all. Now here in this picture, you can see that a man is trying to push a big log of wood. So do you all think it is a push force or a pull force? Well, definitely it is a push force. Now the question here is, does it matter how much ever force he uses here? Does it make a difference? Now, if you all think it does make a difference, then this lecture is for you all. So same thing applies in the oral cavity. Whenever there is a force, be it a push, a pull, or be it any kind of force, when you apply a force onto your dentition comprising of 32 teeth, how does it matter? Or does it matter? If it does, yes. How does it matter? Same thing when it is an intact dentition and the dentition which is replaced by a restoration, how does it differ? So I would like to welcome you all to my lecture that is on biomechanics of restorative dentistry. Myself, I am Dr. Jessle Ansel, Assistant Professor from the Department of Conservative Dentistry and Endodontics, uh, Enamel Dental College, Mangalore, Karnataka. So these are my contents. So what is biomechanics? Bio meaning living tissue or biological systems, and mechanics is the study of loads and stresses. So here we deal with the stresses and deformation that occur in the biological system, and system we talk here is about the oral cavity. How does a tooth respond to the various forces, be it masticatory force or any sort of external force? How does the tooth respond? Now, being in the oral cavity, a tooth can have 6 type of movement, okay, 6 directions. That is labial, lingual, mesial, distal, or in a incisal or apical direction. So we can put up in this way that it has got an omnidirectional movement. And again, the movement or the freedom of displacement again depends on how well it is attached to the alveolar bone or the socket, how well it is supported by the adjacent tooth, and also how far is the muscular activity of the person or the patient. Here, when I talk about muscle activity, I mean the muscles of mastication. So if a patient is having a hypertrophic masseter muscle, for example, the patient is going to exert more amount of masticatory forces, which in turn will contribute, which in turn will necessitate a greater amount of resistance to the occlusal forces. So first, we'll discuss how strong is our tooth. So a tooth comprises of enamel, dentin, pulp, cementum. So enamel being the outermost layer, how strong is the enamel? Now we all know enamel is one of the hardest or the rigid structure in the body. So it is having a high elastic modulus and a low tensile strength. Now coming to the hardness of enamel, enamel has got a higher harder surface is onto the harder enamel is onto the surface, and as we go deep onto the dentino enamel junction, the hardness decreases. Same thing is applicable to the density of enamel as well. So the density also considerably decreases as we move on from the surface to the dentino-enamel junction. Now again, when the enamel is protected with the support of dentine, that is a proper dentine base is there for the enamel. In such cases, the strength of the enamel will be more. When the enamel loses this support of the dentine beneath it, it loses almost 85% of its strength. So as long as the enamel is supported by a vital dentine, the enamel is strong enough, or we can call it as a hardest structure. The moment the enamel rods fail to possess a dentine base, there is going to be fracture of enamel. So in cases wherein there is a backward caries, when the caries initiates from the dentino-enamel junction and later it progresses to the enamel. In such cases, though we have an intact enamel, the dentine beneath it would be weak or compromised. In such cases, the enamel also reduces its strength. Coming to the force resisting structures in enamel. When we say that enamel is strong, enamel is hard, or enamel is rigid, what makes enamel hard? So first thing is the gnarled enamel within it. These are the groups of enamel rods that may entwine with the adjacent groups of rods, and they follow a curving irregular path. So in this picture, you can see that the usual enamel rods will be in a curving manner. But in some areas, there you will see that these enamel rods are in groups and they are found entwined within themselves. Okay, so these comprises enamel rods with gnarled enamel, which occurs near the cervical region and the incisal and occlusal areas. Gnarled enamel is not subject to cleavage as it is hard. So it is more hard and it is tough for fracture. So gnarling of the enamel rods provide strength by resisting or distributing and dissipating the occlusal forces. Next is the Hunter-Schriger bands. They are the changes in the Hunter-Schriger bands occur due to the changes in the direction of the enamel prisms that minimizes the cleavage in the axial direction. So this is the usual direction of the enamel rods. Hence, whenever the occlusal forces are there, there is going to be the forces will be dissipated in this manner towards the dentine. As and when there is a change in the direction of the enamel rods, the forces will be distributed in an uneven manner. So there is less chance of fracture. Like how there are stronger structures, enamel also comprises of few weaker structures. That is enamel lamellae. It is thin leaf-like folds between the enamel root groups, excuse me, that extend from the enamel surface towards the dentino-enamel junction. They comprise, what makes it weak? Because it comprises of organic material that is weak area and making it a predisposing factor for dental caries and bacteria. Coming to the biomechanical properties of dentine. Now after enamel, we have the dentine. So dentine is not as hard as the enamel, hence it is softer, but then it is harder than the cement. Now the hardness of the dentine averages on 1/5 of the enamel, but then it is almost 3 times than the pulp. Dentine, unlike enamel, hardens over the age, and hence we can say that if we compare the primary, secondary and the tertiary dentine, the tertiary dentine will be the hardest. It is because of the increased mineralized tissue onto the tertiary dentine, and the modulus of elasticity is almost in the range of 1.6 into 10 to the power of 6 pounds per square inch. Often we see few craze lines in the tooth. Okay, so we see it mostly in the enamel, but then it is not clinically very significant unless and until it is associated with an underlying crack within the dentin. And dentin is not as prone to cleavage as in the enamel root structure. The tensile strength of dentin is 40 megapascal and the compressive strength is around 266 megapascal. Next is the functional aspects of dentation. So now that we know what makes enamel, dentin, and various substructures hard, we need to know what a few basics of occlusion. Now, how does the teeth, the opposing teeth, occlude while in contact? So there are various kind of tooth contact. The basic contact is the cusp to fossa contact. Whenever the upper maxillary arch occludes onto the mandibular arch, the cusp tip of the maxillary tooth occludes onto the fossa of the mandibular tooth. And when it comes to surface contact, we have the ideal situation wherein the mandibular incisal edge comes in contact with the lingual slope of the maxillary incisor. In cases of class 2, you see the mandibular central incisor ridge, incisal edge comes in contact onto the cingulum of the maxillary central incisor because of the protruding maxilla. And in case of edge to edge, the mandibular incisal edge along with a part of the facial surface comes in contact with the lingual slope of the maxillary incisor. And when it comes to the class 3 case, here we can see a reversal of contact. Here the lower mandibular incisor is ahead of the maxillary incisor because of the prognathic mandible. Hence, the facial surface of the maxillary incisor comes in contact with the lingual surface of the mandibular incisor. Say next is the ridge embrasure contact. So here embrasures are nothing but the spillway spaces which maintains the oral hygiene in case of a dentition. So it is very important that we maintain the ridge to embrasure contact. So whenever we see for the occlusion, the embrasure should come in contact with the ridge of the opposing tooth. So every embrasure in the lower arch should meet with the ridge of the upper arch, upper tooth. So coming to the posterior cusp characteristics, ideally, 4 cusp ridges can be identified for all the cusps. Uh, each cusp has got an outer incline and an inner incline. The outer incline either faces the facial or the lingual surface of the tooth and is named for its respective surface. Coming to the inner incline, these are widest at the base and it narrows as it progresses towards the cusp tip. So you can tell this as a triangular shape. Okay, so the with the broader base at the central region and tip at the cusp tip. Hence, we can also call them as triangular ridges. Then next is the mesial and distal cusp ridges. They also extend from the cusp tip mesially and distally and are named in their own respective directions. Next is the supporting cusp. Supporting cusps are the functional cusps. It is characterized by 5 features. They contact the opposing tooth in the mandibular arch and they support the vertical dimension of the face. They are nearer the facial-lingual center of tooth than the non-supporting cusp. Their outer incline has the potential for the contact. So the supporting cusps have broader and more rounded cusp ridge than the non-supporting cusp. Now broader, why broader? Because the broader the supporting cusp, the more it will withstand the occlusal forces. So now let us see which all are the supporting cusps in the maxillary arch. In the maxillary arch, it is the palatal surface that comes into contact with the mandibular teeth while in occlusion. So it is the palatal cusps starting from the palatal cusps of the premolars and mesiopalatal and distopalatal cusps of the molars, first and second molars, that they are the ones which occlude while in contact. So if we can draw a line connecting all these tips, we will get a lingual occlusal line in the maxillary arch. Coming to the mandibular arch, it is the buccal surface of the mandibular teeth that comes in contact with the maxillary tooth. So when you draw a line connecting all the buccal cusps starting from the canine to the buccal cusps of the premolars and the mesiobuccal and distobuccal cusps of mandibular first and second molars, we will be getting a facial occlusal line. Cusp tips on the functional side are demarcated with the blue line in the maxillary arch and with the red blue dots in the maxillary arch in this picture and red dot in the mandibular arch. Apart from the supporting cusp, we have the marginal ridges and the crossing ridge or the oblique ridge. Now, in case of a maxillary first molar, the oblique ridge traverses from the mesiopalatal cusp to the distobuccal cusp. And we always see the concavities or the treated bare facets in patients with masticatory problems, that is bruxism, clenching, grinding. So they, in such cases, you will be seeing treated bare facets, especially on the functional cusp. Coming to the biting forces, now how much force do we exert while we bite? So biting forces, maximum biting forces are onto the molars, that is first molar and second molar. About 580 newtons of force is being applied. When it comes to the premolars, canines and the incisors, the forces decreases to 310, 220 and 180 newtons respectively. Let's move on to the principles of biomechanics. So whenever there is a stress transfer and the resulting deformation of the structures, it is principally governed by three factors. That is the elastic limit of the material, ratio of elastic moduli involved, and the thickness of the structures. Now, coming to the mechanical properties of the restorative material. First and foremost, we need to understand the concept of stress. When do we call it a stress? Whenever we apply a force onto a material, the material initially will try to resist the external force to how much ever limit possible. Now, the force that is distributed over an area and the ratio of the force to the area is called as a stress. So you apply some force onto onto a surface. Smaller the area, larger will be the value of the stress. The same force, if you apply onto a larger area, the stress in turn will be reduced. So these are the various stresses which we have. Coming to the tensional stress, when you subject two sets of forces that is directed away from each other in a straight line. So this is the straight line which we talk, and you have two sets of force. One is towards this direction and the other one is towards the other direction. So they are directed away from each other. So that is when you get a tensional force. For example, when you try to uh, stretch a rubber band, okay, there is a tensional force. Same thing. Second type of stress, that is a compression stress. When you subject two sets of force in a straight line which is directed towards each other, that is when you get a compressional stress. For example, when you are kneading a chapati dough or something, you always tend to do like this. Okay, that is a compressional stress that you're trying to incorporating onto it. Next is the shear stress. Shear stress is found to be seen when two forces are parallel to each other and they are in the opposite direction. So a sliding force is what we talk about. So there is two sets of forces, but they slide onto each other. Okay, they are parallel to each other, but they are sliding. Now this picture denotes the cross section of a tooth wherein you can see the same tooth when subjected to a masticatory force will develop all kinds of stresses: compressive, tensile and shear stress. So it is very important for us to know which area you are restoring and that area was bearing what kind of stress. Accordingly, we have to choose the restorative material. Now, initially, when there is a small amount of force, the tooth will obviously try to resist the force. But as and when the force increases, the stress increases. So the loading continues. As the loading continues, the structure is going to get deformed. At first, it is going to be a reversible deformation, or that is when you call it as an elastic strain. Now, what happens when there is stress further beyond the limit? That is when you get a deformation. This deformation is what we call as a strain. Now when the deformation is a reversible deformation, that becomes an elastic strain. However, when it has reached a limit wherein there is further irreversible strain, that is when we call it as a plastic strain. So this causes a permanent deformation. Now, the point of onset of the plastic strain, okay, is called as the elastic limit or the proportional limit. So here, till here, the stress strain graph was progressing in a uniform manner, okay. But then further beyond this, when you apply force, the material can no longer resist, or there is going to be permanent deformation. That is when you call it as an irreversible strain. That point until which the material resists the stress, that is called as the elastic limit or the proportional limit or the yield limit. Now the maximum strength a material can resist before it fractures, that is the ultimate strength. So whichever material of choice we opt for, we need to know the ultimate strength, as in how much strength can the material bear before it fractures. And we need to check the masticatory force onto that tooth. So the material should have the subsequent masticatory force limit, only then it can bear the occlusive force. Now coming to this diagram, the slope of the linear portion of the stress, this is a stress strain curve. So here the slope of the linear portion uh, denotes the modulus of elasticity or the stiffness of the material. So it is abbreviated by E, and further, so this is the modulus of elasticity. So this is the elastic limit. From here to the yield strength, it is the area wherein you have the elastic strain, and then further from here to here you have a plastic strain, and then further beyond the ultimate strength the material tends to fracture. So a material generally should be very stiff so that under load, its elastic deformation is very small. So a restoration can be classified as a clinical failure when a significant amount of permanent deformation takes place, even though when the material does not fracture. So sometimes we might think that, oh, okay, material is the restoration itself is intact, so we need not change. But many a times we forget to think that even though when you see the secondary caries or a marginal leakage, that can be due to the deformation that has taken place. So that itself is an indication of a clinical failure. Why? Because of the permanent deformation, there is going to be gaps or micro leakage, and in turn it will cause secondary caries. Now, coming to the stress at which the fracture occurs, that is, I told the ultimate strength. So we need to know the ultimate strength of the tooth, that is of the enamel, and also of the material of choice for restoration. So various restorative materials have got various tensile strength and the compressive strength. So we need to always check it with the tensile strength of the and compressive strength of the enamel. Enamel has a tensile strength of 10 megapascal and a compressive strength of 400 megapascal. So these are the values of the various restorative materials that we have. So always when you choose a material, we need to analyze how good is it when you compare it with the enamel. Next is the fracture toughness. It is the measure of the energy required to fracture a material when a crack is present. So some materials do not plastically deform easily. So hence they are more susceptible to cracks and defects. Dental porcelain is an example with of such material with a low fracture toughness value. Um, Coming to the metals, they have a higher fracture toughness value. Next factor is the creep. Creep is the time-dependent plastic deformation. Um, so why is it important? Because now when you restore the tooth with the material and you leave it over a period of time, you see that there is going to be some amount of micro leakage or discoloration onto the remaining tooth structure. Why has this happened? Now in this picture you can see that, that there is an amalgam restoration which is a class 2 MOD with a palatal extension. So the remaining tooth structure left out is very less and you have a very large restorative material here. So all around the cavo surface margins, you can see there is a discoloration. Why would have this happened? Why would have this occurred? It can be because of the deformation that has taken place within the restorative material over a period of time. And there is micro leakage and seepage of the oral fluids, which in turn gives you the secondary caries or a discolored intact tooth. Next important factor is the biomechanical unit, which we need to know. Now, when we deal about biomechanics, it is very important for us to know what all comprises in the biomechanical unit. Now, we have a intact tooth, a restorative material, and an interface between these two, that is the restorative material and the intact tooth. The interplay of all these three units tells you the story of biomechanics. Different restorative procedures can have various interfaces. Like for a composite restoration, it can be a micromechanically bonded interface, but in case of an amalgam, it can be a mechanical interface which is weak and continuous unless we use a bonded amalgam restoration. And when it comes to a cemented crown or enamel surface, they are again weak but are continuous. Importance of considering these three structures, that is the restoration, the tooth, and the interface, is to detect that stresses may cause unwanted fracture or the debonding. So we need to analyze So in some cases, even though the restorative material is stronger and resists fracture, but the interface might be a weak interface. Why? Because it is not bonded well, or it is not sealing the entire interface. So in such cases, again, the biomechanics can alter. So all three factors should be taken into consideration. They interplay in order to ensure a good biomechanics. Now, coming to the stress transfer in the normal teeth and the restoration. Now, in a normal teeth, whenever you are subjecting the tooth to occlusion or masticatory forces, the forces will be dissipated all around the surface area of the intact enamel, dentin, pulp, and the cementum and the alveolar structures. So, there is a uniform distribution of the concentrated external loads. Hence, there is going to be more surface area and less stress onto the dentate. So, there is going to be very less deformation and flexion. But when so in this picture, you can see picture A denotes how the forces are going to get distributed in case of a normal intact tooth. And picture B shows the same occlusal forces, how will it be distributed when you have a restoration. Now, when you have a restoration, the remaining tooth surface or a remaining dentine thickness is going to be compromised. So, especially at the interface, whatever force that comes onto the tooth, the maximum amount of force distribution takes place at the interface. From the interface, there is hardly any remaining dentine thickness towards the pulp. So that is why the, the surface area reduces and there is going to be more stress in such cases. So you should be always keep this point in mind, that is most of the restorations are designed to distribute stress onto the sound dentine rather onto the enamel. So once in dentine, the stresses are resolved in a manner similar to that of the tooth. Now, whenever the remaining dentine thickness is compromised, that is when there is going to be stress transfer, more stress transfer onto the dentin. Next is the Wales experiment, wherein he has told how much of the um, percentage of loss of tooth resistance to splitting is there when you do different type of cavity preparation. Now, when you involve one marginal ridge in a conservative cavity preparation, that is with 1/4 of the intercuspal distance, you are compromising almost 10% of the loss of the tooth's resistance to splitting. Again, when you cross over the second marginal ridge, you are further decreasing it to 15%. When you increase the width of the cavity to a conventional cavity preparation by including 1/3 of the intercuspal distance, there is further beyond 30% loss. And when you again involve the second marginal, that is both the marginal ridges are involved, that it becomes 35% loss. Next is the case wherein you are increasing the width of the cavity by 1/2 of the intercuspal distance. Again, you are causing a loss of 40%. And when you involve both the marginal ridges, it is going to cost you 45% loss of a tooth's resistance to splitting. Further beyond, by crossing the oblique ridge at 1/4 of the intercuspal distance, it reduces 20% of the loss of the tooth's resistance. And further, 35 and 45% when you go for a conventional and a cavity preparation, which includes almost 1/2 of the intercuspal distance. Now, another factor is the design of the cavity. Now, when you choose, here you can see three types of cavity designs. This is the box-shaped cavity design, this is the inverted cone shape, and this is the cone shape. Now, inverted cone shape has a higher resistance to loading than the box shape. So when you compare this to this, yes, inverted truncated is good. Why? Because the surface area is less here. So the final stress is going to be less. Now next is the box cavity. The box cavity preparation, it will have higher resistance to loading than the cone shape because it has even higher it has a broader surface area. Also, we need to check that we don't give a sharp point angle, especially when it comes to an axiopulpal line angle or point angles when you do a class 2 cavity preparation, as these point angles and line angles may cause stress concentration, stress bearing areas. So we need to round off all the axiopulpal line angle and stress concentration areas. Now let's move on to the mechanical problems in a class 1 restoration. Class 1 restoration, the advantage of it is that it has a mortise shape. Each wall and the floor is in a form of a flat plane meeting at each other at a definite line angle. Hence, the seat of the restoration is a distinct right angle to the direction of the stress. Plastic materials are readily compacted against the smooth, flat, plane surface of the mortise. So you'll be able to compact the material all around the line angle and the floor of the cavity. Also, a mortise formed with two or more opposing walls facilitate the gripping and frictional retention of the plastic restorative material in a cavity preparation. So, in this case, when a caries cone penetrates deep onto the dentin, removing the undermined caries may lead to a conical or a hemispherical preparation. So, this will result in a very thin remaining dentin thickness. So, that will further increase the stress concentration. So here, if you can see, when you apply a force in a centric manner, the restoration will act as a wedge and it will concentrate more amount of force onto the pulpal floor. As such, the dentine bridge or the remaining dentine thickness is very thin here. Hence, there is high chance for the tooth to split into two pieces. So solution, what you can do here is, you don't have to take the entire floor beneath when the caries is only at the central portion. You remove only the central portion, so at least this much part of the tooth structure is preserved. Coming to the class 2 cavity preparation, here we need to see the instance or the scenario. When a small cusp contacts the fossa, so here this is the maxillary tooth and this is the mandibular. So the small cusp of the maxillary tooth is contacting the fossa of the mandibular tooth, which is away from the proximal restoration. Okay, in such cases, there is tensile stress that is occurring at the isthmus of the mandibular tooth, and there is compressive strength that is passed on to the underlying dentin. Say, now, this is a situation wherein the large cusp contacts the fossa that is adjacent to the restored proximal surface in a proximo-occlusion direction. So, unlike in the previous case wherein the cusp was occluding onto the area fossa which is away from the proximal restoration, in the second scenario, the large cusp is contacting the fossa which is adjacent to the restored surface. So here the large cusp will tend to separate so there you can expect a separation of this proximal surface of the restoration as there is a tensile stress within the isthmus, and the compressive stress in the remaining tooth structure uh, develops in the apical direction from the apical end of the restoration. But here the compressive stress, since it is in line with the long axis of the tooth, that is taken care of. But the tensile stress will lead to fracture of the proximal part of the restoration. Now coming to composites. In composites, there are various wear forces acting. So there are at least 5 types of composite wear events. It can be the contact-free area, that is the wear by the food we intake, okay, that is called as a contact free area. The impact by the tooth contact in centric. Now when you eat something, the food itself can act as a wearing agent. When you occlude, there is occlusal contact area. So this is the occlusal contact area where, and sliding by the tooth contact in function. So when you have a functional movement, okay, so you tend to move the tooth in the lateral or in the centric or eccentric manner. That is when you have a functional wear. So that time the wear is mostly seen onto the cuspal slopes. Next is the proximal contact area. Here, that is the rubbing of the tooth contact. So tooth to tooth contact. And also you tend to put something because of food lodgement in the dental area, that also can attribute to proximal contact wear. Now, fifth one is the wear from the oral prophylaxis methods, that is dentifrice abrasion. Now, where patients with heavy occlusion, such as bruxism or restoration, that provide all the tooth contact of the antagonist may lead to the failure of the restoration. So, in patients with bruxism, we need to check the occlusion prior to the restoration, because of the heavy forces of occlusion. If you keep the restorative material exactly at the contact points of the agonist, that is the opposing tooth, it might lead to the fracture of the or the dislodgement of the restoration. Another key factor in case of composite is the polymerization shrinkage. As a in longer period of time, the composite material tends to shrink. So the polymerization shrinkage of composites in cavity generates a stress that can be transmitted via the adhesive interface to the adjacent tooth structures. And hence it can give you, it can lead to dental deformation and reduction in the intercuspal disc. So when you restore this area and when there is a shrinkage, the cusp tends to deflect to each other. So there is an intercuspal flexure, and the intercuspal distance, it reduces when the cusps tends to move to each other. Because of the cuspal flexure, the intercuspal distance reduces. So the buccopalatal dimension which was there before will reduce. These forces, in addition to causing cusp flexure, can cause fracture or crazing of the enamel and the fracture in the composite material. Now again, C factor or the configuration factor, that is the ratio of bonded to unbonded surfaces. Again, because of the C factor, the polymerization shrinkage can increase, and hence it is told that class 1 showed the higher degree of stress than the class 2 restorations. Class 1 has a C factor of 5. Hence, the polymerization shrinkage also increases. Coming to the forces acting on anterior tooth. Now, what are the unique features of anterior teeth? Anterior teeth have the maximum bulk in the gingival area. So, this part of the anterior tooth is more bulky than the incisal area. Again, coming to the labial and lingual, labial enamel plate is much thicker than the lingual or the proximal ones. Also, occluding surfaces of the anterior are anterior determinants of the mandibular movements. So, for more deeper the bite, more deeper the overbite, more stress on the anterior tooth. Okay. Now coming to the forces acting on the anterior restoration, whenever there is a force that is acting on the anterior restoration, it can be displaced onto a horizontal component and a vertical component. The horizontal forces displaces the restoration in a lingo-proximal labial direction or a lingo-proximo-labial direction, that is from here to here, or from the proximo-lingual direction. Okay, and the vertical forces which tends to displace the restoration proximally. In occlusions with deep anterior bite, and example in this case, you see that the horizontal forces will be exaggerated rather than the vertical force. And in cases where there is an open bite, there is no question of contact. Hence, there is not going to be any vertical or horizontal component. Whenever you convert a class 3 situation onto a class 4 situation, that is another major complication, because in a class 3 situation, the occlusion is not, the occlusal force is not coming directly onto the restoration, but there is an intact tooth in between the opposing tooth and the restoration. But whenever you convert the class 3 to a class 4 restoration, there is direct loading of the restoration. So loss of an axial angle, incisal angle, or a tooth structure at the cervical region can dramatically reduce the tooth's ability to resist the loading. Ideally, a restoration made of the tooth-colored material should not be loaded directly. Also, when you see the root canal treated tooth, when you go for a root canal treated tooth per se are very brittle than the normal teeth, and onto that, in some cases, because of the grossly decayed tooth structure, we might have to place a cast post. We might have to place a post and core restoration. So again, post and core can be a cast post or a fiber post. Now, a tooth restored with a stiff cast post system was observed to withstand higher load of occlusal force before it fractured. But again, the fracture was more catastrophic and it would result in extraction. But when it comes to fiber posts, that is in this picture, they demonstrated lesser strength, but then it gave more repairable fracture modes. So with this, I would like to conclude by telling that occlusion plays a very important role in the longevity of the restorations that we do, in the functional movements of the teeth, and the function in the functional aspects like mastication, TMJ disorders, and everything. So whenever you do a restoration onto the oral cavity, please keep in mind about the various biomechanics of the tooth and the restorative materials we have. You cannot do a restoration blindly without knowing the biomechanics behind it. When you choose a restoration material, you need to see that it is in synchronous or in alliance with the properties of the tooth which you have removed because of the cavity preparation. So knowing what is the biomechanics of the normal dentition and knowing which material you are choosing, the biomechanics of that material, and in turn knowing the biomechanical unit plays a significant role in the longevity of form, function, and duration of the restoration. So with this, I would like to end my presentation. I would like to once again thank the organizers for giving me the opportunity to share my insights regarding this topic.